Good morning, everyone. We are going to get started here in about 60 to 90 seconds. We're just going to let folks kind of filter in as we open up the room. And good morning, everyone. And we want to thank you for joining us today for today's webinar. My name is Colby Reed. I'm the Director of Communications for the MJ Murdoch Charitable Trust. And it is my pleasure to welcome you to Lifting the Fog, Preparing for the Next Pandemic. We are thrilled to be joined today by Elise Takahama, Dr. Helen Chu, and Dr. Molly McNairy for this conversation. I want to start off today just by quickly thanking the Seattle Times for their partnership in this series. There are some really complex challenges that are facing our communities in the Pacific Northwest. There are a lot of mixed messages, a lot of confusing information that is circulating in the public discourse. The goal of the Murdoch Trust is to support the social, cultural, educational, and spiritual fabric of this region, and conversations like the one that we're going to have today are central to that mission. Our goal with the Lifting the Fog series is to bring trusted voices together to talk through the facts, clear the air so that we can all move forward in ways that serve the common good. We do hope that you will join us for some upcoming conversations that we will be having on climate change and bridging political divides. Those are taking place in August, and we will have registration information out for those shortly. A couple of brief housekeeping items before we get started. We will have time at the end of today's discussion for some audience Q&A. So if you have questions, please submit those into the Q&A box below. You can also upvote questions that you think are of particular value, and we'll get to as many of those as we can. We will also be posting a recording of this session on the Murdoch Trust website shortly after today's event concludes, and we welcome you to share that with anyone in your network. With that, it is my pleasure to turn things over to our moderator to introduce our two panelists for today. Our moderator, Elise Takahama, covers health and hospitals at the Seattle Times and has been reporting on the pandemic for the past 2 years, including how healthcare systems have responded to staff shortages and high patient loads, how the state sequences genomes, and how local COVID policies have unfolded. She also has a really interesting story today about vaccine trials that we would encourage everyone to take a look at. Prior to the Health Beat, she covered crime and breaking news in Seattle. I'd like to welcome Elise Takahama.
Hi, good morning, everyone. Thank you so much, Colby, and thanks to the Murdoch Institute for hosting this today. So as Colby said, yeah, I'm a reporter at the Seattle Times, and today I'm lucky enough to be joined by two infectious disease experts. We have Dr. Helen Chu, who is an associate professor at the University of Washington School of Medicine and School of Public Health, and an expert on respiratory viruses and vaccines. She has made substantial contributions to the COVID-19 response in Washington state. And along with a team of scientists, she also leads the Seattle Flu Study, which is focused on pandemic preparedness and first identified COVID community transmission in the US. Dr. Chu has also established the first cohort of COVID survivors in the US, which allowed for major early contributions for development for treatments and vaccines for SARS-CoV-2. And she's also worked closely with local public schools in Snohomish, Seattle, and Yakima to do studies in young children to understand testing and school-based transmission, and has led the Husky coronavirus testing program for UW students, faculty, and staff. Dr. Chu has also worked with underserved populations, including houseless folks in Seattle, and she serves on the National Institutes of Health's expert working groups for maternal COVID vaccines, COVID, and respiratory viruses. As an acknowledgement of her contribution to the statewide COVID response efforts, she received the Researcher of the Year Award from the Puget Sound Business Journal, the Shiro Award from the National Organization for Women, the UW School of Public Health Changemakers Award, the Seattle Mariners Hometown Hero Award, the Seattle Seahawks 12 Flag Raiser, and the Washingtonian of the Year Award from the state of Washington. And zooming in from the East Coast today, we also have Dr. Molly McNairy, who's a global health physician scientist with over 15 years of experience as a frontline doctor and public health researcher. Dr. McNairy is an associate professor of medicine at Weill Cornell in the Center for Global Health and an attending physician at New York Presbyterian Hospital in New York City. She graduated from Harvard Medical School and completed her training at the Brigham and Women's Hospital in Boston, and also completed a Fulbright scholarship in health economics at the London School of Economics and the London School of Tropical Medicine. Dr. McNairy brings expertise in international epidemics, having worked as a physician providing direct medical care to patients living with HIV, tuberculosis, cholera, malaria, and COVID in India, Africa, Haiti, and New York City. Since March 2020, she's also treated COVID patients who are hospitalized in New York, and she leads research on COVID and cardiovascular risks. Dr. McNairy has also published extensively on how COVID has affected physician well-being, medical education, and long-term patient outcomes. And she's received awards for her work and mentorship of trainees, and her research has been funded by the NIH, CDC, and numerous foundations. Dr. McNairy is also a consultant for Epidemic Intelligence, which is a public health consulting firm that advises schools, organizations, and businesses on COVID workplace safety, risk reduction, and outbreak preparedness. She lives in New York City with her husband and 3 children, ages 5, 8, and 11. So clearly we have a lot of experience between our 2 panelists today. And so I wanted to start by talking a little bit about what was going through both your minds early in the pandemic. As we know, most people hear about an outbreak that's reached the US every few years. And in the past couple of decades, we've had bird flu and swine flu and Ebola. But those are often in the background for most of us and just didn't pose the imminent threat that COVID has. So going back in time prior to 2020, what were both your mindsets about how likely a global pandemic or a US pandemic was? And Dr. Chu, do you want to start?
Sure, I'd be happy to. So thank you for that kind introduction. Again, thank you to the Murdoch Trust for inviting us to speak to you today. And I'm really honored to be here with Dr. McNairy to go over these questions and these pressing issues. So, as part of a team of investigators who we were already thinking about pandemics. When we designed the Seattle flu study back in 2018, it had been 100 years since the 1918 flu. And we understood that we were in a place where another pandemic was inevitable. And it was just a matter of time. We had seen sort of the acceleration of the different pathogens coming through, Zika, Ebola, H5, avian flu, all of these things were coming and they were accelerating because of just sort of how much global travel and how much was happening at sort of the human-animal interface. And so when we designed the Seattle flu study, it was really sort of to think about what were the missing gaps and what we could do to change things to make us better prepared. And so at the time, when we took sort of a look at the situation, what we knew was that there were surveillance systems in place through the CDC. And these really captured a lot of information that was coming in through hospitals and through laboratories, but really were not well designed to capture data that was coming in from the community itself. So people who are not necessarily accessing care. And then we also knew that the data systems were not very good. So that the way that you would get the information about, say, vaccines or test results, those came through Excel spreadsheets that were sent from the lab to the Department of Health. And that was just not that timely, nor was it very complete. And then we also felt that one of the key things that would be really important would be genomic sequencing, and that understanding really how the virus is mutating in a community would give us answers to the path that it would spread within the community, and also more importantly, how it was introduced. And so when we designed the study, it was really to answer those questions, to answer the questions around, can we look in the community? Can we then link the data very, very quickly? And then can we do genomic sequencing and then visualize that data so that others could use that information to make decisions? And I feel like now, 3 years later, 4 years later, we are now in a position where those things are commonplace, that we actually do those things. We are collecting many more samples. The data is much more complete. The integration of the data is also much, much better. And clearly, I think the world has seen the value of genomic sequencing and its role in both understanding how viruses mutate over time, and then how these new variants are causing disease in individuals.
Definitely. And so Dr. McNairy too, working in New York and also in other parts of the globe, did you also feel that from a global perspective, our health systems weren't, quite where they needed to be?
Yeah, just to echo Dr. Chu, thank you for having me. It's an honor to be here and engage in this discussion and brainstorm together. So my perspective is a bit the different lens. It's the global lens. So I've spent most of my medical training and professional career working in really poor countries around the world, in Africa, India, and Haiti, that have extreme poverty and, if anything, nascent health systems. And my work specifically is trying to partner with ministries of health to build health systems to deliver better care for surveillance, diagnosis, linkage to care, and treatment. And the whole motivation for me in medicine is that no one, no matter where you're born, should die of treatable diseases. So after years of working with other countries to build their health systems and going sort of from 0 to maybe even 50%, I intellectually knew that we could have a respiratory pandemic globally, that it could come to New York. And we've had the harbingers of that with previous SARS and other viruses. But life is a lot about contrast, and the contrast of the magnitude of suffering from epidemics of HIV and MDR TB in the countries I worked with compared to US health systems, which were much more robust. I, inappropriately assumed the US didn't have as many weak links in their system as I think we've seen over the past 2 years. And thanks to studies like Dr. Chu's in Seattle flu study, she was beginning to piece together, like, what are the gaps and where do we need to fill the gaps in the health system? But I think nationally, there's still a lot of work to do there. So my head was in the ground, and I am not surprised, but I had a faulty assumption that the US would be able to have a more robust response.
Got it. And so what were some of your first experiences dealing specifically with COVID then early on when that did start to travel around the whole world?
Sure, I'll go pipe in here. So I live in New York City, as you said, and I work in a hospital here. And so my job's sort of a mix on faculty at Weill Cornell of global health research and then clinical care, taking care of patients who are hospitalized in our hospital, many of who end up needing intensive care. And I remember distinctly March 13th, it was a Friday, and it was sort of this dichotomous cut where New York City went to ground, and COVID was here, and all essential businesses were if not shut down, very stalled, and yet the hospital doors were overflowing, and every doctor part of our health system was called in, almost like a military deployment of come and help because the ER is full of patients. And patients, if doctors in the hospital, you expect to see patients who are elderly or who have end-stage diseases coming through. But what was overwhelming is these were young people coming through, people in their 30s and 40s and 50s who had no past medical history and were very, very sick. And the second thing was that how sick they were. So typically when you're caring for patients in the hospital, and Dr. Chu can give her experience too, but 10% are what we call sick, which is just slang for like medical students and residents on your team. Go look at these patients every hour because they're so sick or worried they may not make it. And in contrast, in COVID, those early days, it was 90 to 100% for sick. So that like adrenaline and worry of a clinician was so high. Coupled with that, there was a lot of emotion. So there was this radical helplessness initially of not being able to give a clear diagnosis because we lacked testing it early on. And then when we had testing, there were some delays. Clearly that scaled up since then, but that early feeling of like, this was a diagnosis of a exclusion. And then we didn't have treatment. So we had oxygen and we could put them in queue for a ventilator, but we didn't have treatments. And as doctors, that's our toolbox is prevention and treatment. And we sort of felt handcuffed. And then there was the fear, right? There was a lot of fear that you were managing on your teams of nurses and respiratory techs and students of, could you get the virus? So all coupled together, it was very, I would say emotional. It was very sobering. It was very lonely. And one of the things that I've written about, but also just pursued as a sort of a new part of my research portfolio is the loss of human connection in COVID. And unlike working with HIV and TB patients in the poorest parts of Southern Africa, part of medicine is the ability to touch patients and bear witness to their suffering just by being with them in a room. And that was stripped in COVID. You have this PPE that we can talk about, but it was basically plastic, and it was layers of plastic, and you felt parched and dizzy, and you could barely talk, and you would rush into the room to not spend too much time to have COVID be transmissible, and you couldn't really stand and support your patients, human to human. There was no skin to skin contact. There was no extra time for a joke. There was no extra time to find out something about that patient. It was just rush. And I think that is the sort of loss of the human connection in those first 6 months of the COVID clinical experience and such high death rates was going to affect the career paths of many of our trainees moving forward.
Definitely. And so, just because I know there's a lot to get through today, but moving forward in time, we saw how awful those first few months were, as you're talking about, Dr. McNairy. And so moving forward in time and even to last year, and as we were getting through some of these later surges, how did both of your roles in dealing with this historic challenge start to change and evolve? And Dr. Chu, we can go with you first this time.
So at the beginning of the pandemic, we were very much focused on establishing the systems to be able to identify viruses early and then to do the early treatment trials. And like Dr. McNairy, I think it was a difficult time. It was a time of uncertainty. It was a time of fear. And also there is just something about taking care of patients who you knew were going to die, and patients who are young and healthy otherwise, but who were going to die. And that was very hard, I think, at the time, having nothing to give them. And then I think over time, my role is really more in sort of population-based studies and not so much in the hospital. But over time, what's become clear is that this pandemic did not end as quickly as we had hoped. I think many of us early in time thought, well, once we have all of these vaccines and we have effective treatments, the antivirals, the monoclonal antibodies, the steroids, all of those things are really dramatically decreasing the number of people dying from COVID. And then when the vaccines came, I think many of us hoped that would be the end, that would put this to rest, and then we could all go back to normal. But what became very clear fairly early on was that was not going to happen, that people were going to get repeatedly infected over time, that the virus was going to mutate in a way that we did not expect it to mutate so quickly. We really didn't think it was going to mutate this much and that there would be so many variants. And then I think the other thing that was very unexpected at the time for me was just this political divide on masking and vaccines, and that would be something that would actually sort of tear this country apart and establish like the masked and the vaccinated as one group, and then the unmasked and vaccinated as another group. And to see the disparate amounts of suffering and death in that group of the people who are not getting vaccinated, that was very, very difficult, especially on the inpatient side, in the hospital, taking care of patients who were not vaccinated, but were young. This was in the post-vaccine era, right? So people had ready availability and ready access to vaccines, but they were unvaccinated and they were in the hospital and they were intubated and they had a breathing tube and they had, and they were dying and they had young children at home. And that was very, very hard to see. I think that was the thing I was not expecting in the post-vaccine licensure period.
Well, 2 points to build off of. One is that I should have expected it, but I didn't. But the intensity, both the physicality of healthcare workers carrying, extra shifts for patients in the hospital, and the emotionality of caring for people who were dying and their families, right? So you have this direct responsibility to your patient, but also the whole family comes with it, and that's a complex dynamic. And over time, there was no relief for a lot of people, both in New York's healthcare systems, but think about all the healthcare systems in the US that span small rural communities to small regional hospitals where there's no backup. And as Dr. Chu was saying, there also came to be a split where you were taking care of vaccinated patients and unvaccinated patients. And as a healthcare provider, you try to leave all your politics and preferences at the doorstep and just meet the patient where they are. But there is a lot of subtext that goes on, right? When people aren't vaccinated, they could be vaccinated or missed opportunities for vaccination that could save their life, and now you can't save their life. And there was also a lot of anger coming in from the communities with patients, of frustration at the misinformation, at the suffering. And that's all sort of climaxing, I think, a lot in hospitals around the country, creating burnout. And I still think that's a huge topic around healthcare workers that is under addressed and critical right now.
Yeah, definitely. You both just touched on some really good points that I would love to ask more about. And so I guess first off, both of you talked about the stress that came from this political divide. So, in the past 2-3 years now, what have we learned anything about addressing those divides and about addressing pushback on funding or changes on a local or state level?
Yeah, I think what I was thinking about in terms of what we could learn from what's happened is that, we knew about sort of the decreasing vaccine uptake in the United States and globally. We've known about that for a while. I don't think any of us could have predicted how much that would play out during this pandemic. I think a lot of people assumed that because it was such a severe disease with such high mortality that people would be very willing to take a new vaccine. And I think that the things that we probably need to do for better preparedness in the future center on all of the traditional things, better surveillance systems and, better messaging and all of that. But I think also a lot more work done on sort of community trust building. And I do think that working with what we've learned is that, working with trusted community messengers is really important, that getting that kind of message out through people who you already have the relationship with them, that's really your path forward. And then I think that we've also, of course, learned a lot about the inequities in how certain populations just became so much sicker and much more likely to die from this pandemic. And some of the things that we need to do to address those inequities, some much larger things than just the pandemic alone, right? In terms of healthcare access and an earlier preventative care access, and just making putting those pieces in place will make us much better prepared for next time.
There's an interesting story I can share that dovetails with this, is that, a lot of Americans, me in my past included, think that there's a technology hierarchy where it's going to come from developed countries and go into developing countries. But for community partnerships, there's real learning that can come from the South to the North. And a great example was our work with our group in Haiti around cholera. So after the 2010 earthquake, which many of you in the audience will remember, it was catastrophic. It killed hundreds of thousands and left an already fragile health system pretty much destitute. Cholera came rolling through, and it was the largest cholera epidemic in centuries. And at the time, it was all treatment. That was all the guidelines from regional PAHO to WHO to the Ministry of Health. And vaccines were kind of unclear. It was a complicated vaccine to give. It was a 2-dose vaccine. You had to give it in a short period of time. And our group said, look, again, no one should die of treatable disease and preventable disease, and we can do this. And so partnering with community health workers in these slum areas in Port-au-Prince, many of whom were frankly gang members, they, no matter where you are, if you make a $1 a day or $1 million a day, you don't want to suffer and you don't want to die. And health is a human right, and people want to stay healthy. They helped us translate the message of here's a vaccine, here's what it does, here's why I can help you. And we had 96% uptake of the vaccine, such that then there's a tumbleweed that happens where the national policy changes and says we're going to vaccinate the whole country, which happened. And now WHO uses cholera vaccines as part of its arsenal for population health management. So if we can do that in Haiti, I know we can do that in the US, but we have not approached community-based delivery, community-based engagement with the same ingenuity that we've approached vaccine development and manufacturing.
And why do you think that is? Or what are the challenges preventing us from doing that?
Well, go ahead.
Go ahead.
Okay, this is my passion in my research. It's called implementation science, and it's saying, there's discovery of science, and then there's trial to show that it's efficacious in a controlled setting. But then you have an evidence base, be it a vaccine or a treatment, and there's this divide, this no-do gap of we don't deliver it. And historically, we've been around the block so many times: Ebola, Zika, HIV, TB, where we have all this firepower in discovery and manufacturing, but we pause before we do equally good delivery. And there's a whole pedagogy in science and implementation science, and it merges multidisciplinary experts spanning population health management, epidemiologists, behavioral economics, media and journalism to do best practices around delivery. And I think it was going to take as much investment in delivery as we have given the prior steps in the science pipeline, if we're going to really have equitable vaccine distribution and more equitable health outcomes, especially in poor countries.
And Helen, did you have anything to add to that?
No, that's great.
Mm-hmm. Yeah, absolutely. And so, another thing that I know that you both have mentioned, and that kind of might contribute to this as well, but just this idea of the mental strain and the mental toll that the pandemic has had on healthcare workers. We heard story after story about that, especially early on. And is that still continuing today? And what does that look like in your own daily clinical lives?
I would say, Elise, it's not just healthcare workers. It definitely is healthcare workers, but it's healthcare workers plus. And now that I'm talking to and working with businesses and schools and organizations, the workplace is unwell. And, COVID has brought us innovation in the sense that we can live this hybrid work life. But it's also coupled that, work and life are intimate, and wellness and health that were previously businesses delegated to, deal with that after you leave work, be productive at work, and then you deal with your health and you can do your mindfulness at home, now have to address it, because it's so interlinked. And I think I don't have all the answers. I think it's an area where we have to do a lot of brainstorming, but there's a demand for it and there's a real need for it. So I'll just stop there.
Helen, in Seattle, have you seen that that's true as well?
Yes, I mean, certainly I'm probably not the right person to talk about that. Honestly, I don't see patients a ton right now. I've been really stepping away from that to handle sort of the surveillance and the pandemic response on a more outside of the clinical setting.
And Dr. Chu, we need you to do that.
Yeah, absolutely. And moving forward, as you're talking about that, what are some of the main things that both of you are tackling in terms of preventing another future health crisis? What are some of the main issues right now?
So I think that the things that are looming are long COVID. That would be sort of number one right now. I think in terms of the numbers of people it's affecting, and the fact that we know very little about what is predicting it. I think there's a lot of information that we don't know, particularly around whether or not you can do something about it before it becomes a debilitating illness. And I think that's one of the things that I'm particularly interested in is, can we identify early markers that predict long COVID? Are there things that we can do? We know that vaccines certainly reduce your risk, but they are not completely protective against developing long COVID, and that many people with breakthrough infections do continue to go on to develop symptoms that persist past 30, 60 days. And so can we figure out who those people are and what we can do? And then the other things that are sort of at top of mind are things like the newer vaccine platforms, both in terms of the variant vaccines that are now being developed, the mRNA variant vaccines that have just been developed by Moderna and by others, that will probably be really, I think, really effective at preventing severe disease from the newer variants as they come. And I think I would be interested in seeing what the plan is with the new variant vaccines, whether or not those will be used as the boosters for the fall, or whether that will be for something just to prepare for, say, if a variant arrived that's completely different from the original strain that was used for the original mRNA vaccines. And then the last thing, of course, is the under fives, and that's the big question right now of as Dr. McNairy was saying, who's going to actually get that vaccine? What system can we put in place to educate parents so that they'll actually take that vaccine? And then I'm also just interested in seeing how well it does in the community. We know that it's pretty effective. The 3-dose Pfizer, the 2-dose Moderna, they're both good and safe, and they lead to high protective antibody titers. And I know there's certainly a group of parents that have been waiting for a very long time for this to come, and so they can protect their children. And I think we need to be able to figure out both how to get this out, and then how to study how well it's working and protecting these children over time. So those are, I think, variants, pediatric vaccines, and long COVID are sort of the big questions right now for me.
I agree. The long COVID, it's confusing for doctors, for me, and I know it's confusing for those of you in the audience. And it's tricky because it's not always related to how severe your disease was or how many times you got the disease. And the symptoms are quite debilitating and in duration and magnitude. And so it's researchers across the country and including Dr. Chu's group are trying to figure it out. And making that message clear to the public, because that's a long-term threat of, COVID's not over, like we're not lowering the flag. We, maybe moving towards being endemic, and we can talk a little bit about that, but it's still high rates of transmission. One other topic that I'm always interested in delivery, but is surveillance. I feel like Seattle may be the superstar of surveillance. The rest of the country has either deserts of surveillance or very underdeveloped surveillance systems. And another lesson of using what we've done in global health to inform what we can do in the US is, what are quicker ways, cheaper ways, faster ways to get surveillance data that may not be perfectly precise, but on the orders of magnitude are appropriate. And so for an example, in New York, when the Omicron 2 variant came in like the last week of April and early May, surveillance data that was reported from hospitals and clinics to the Department of Health said in New York City, maybe 50,000 cases that first week. And we did a population-based, very small sample where we called 1,000 patients, very small, but it was based on a population. So you could take what the information we got and expand it to like the numbers in the city. And we asked questions about, what kind of test did you get? What was the positivity rate? Do you know about treatment? Did you get treatment? What was your outcome? And we found that infection was around 22-23%, and that equated to 1.5 million. So you're talking 50,000 versus 1.5 million. The orders of magnitude, even if we're not quite precise, are so much larger. And so, this is not my analogy, but like we do a great job on the East Coast of telling you when a hurricane's coming. We give you a watch, we give you a warning, we give you bells, and then we give you, alerts for you to take individual risk reduction, board your house, windows, maybe move inland. And then we give you, population level reduction of like, all right, the policeman's coming to knock on your door, move out. We don't really have that set up, I don't feel like, nationally yet for the COVID and the other and then pandemics coming down the line. And everyone's working with like, how can we do surveillance better? And Dr. I don't know if you have more to talk about like interesting surveillance and how Seattle's sort of being the torchbearer on that.
Yeah, it has been interesting because we did, I think in many ways, have a head start compared to a lot of other places because we were developing a pandemic surveillance platform. And so we've been thinking about this for a very long time. And then
which points to prepare before the pandemic. I mean, like how many times do we have to tell the world that? This is not the first dance we've done.
Yeah, I think that the main things that I would say were really important was sort of the linkage and the electronic data transfer. And I think this is like nitty gritty that maybe now the world is interested in it, but I don't think a lot of people used to be interested in it, is that, you know, things are faxed in, right? Information was getting faxed into the public health departments, and it was faxed on paper, and then you would put it into your spreadsheet. And that is how information was gathered. And that is not a good way to gather information in the time of a pandemic. And so I think that, you know, as I think about, well, what can we do? What do we do now that's better? And what can we do differently? I mean, obviously the big thing that we're missing right now is the home testing. And I think if we don't have that home testing data and we are relying on laboratory-based data and hospitalization data, that puts us several weeks behind and does not allow us to be sort of ready for the hurricane, right? So we will only know when the hurricane is here and the hurricane is really sort of lifted the roof off your house. You will not be able to say, well, it is coming. And so I think the ways that we can do that is we just need to establish a system to capture home test data. That it has to be something that where, you know, I think we do get stuck in sort of this idea of, you know, we have to get it right. We have to get it perfect. But really what you need to do is just start doing it. And once you start doing it, then you figure out what's wrong. And you can do sort of some back end calculations to adjust for like, well, this kind of data that we're getting is only from these people. And so we will adjust it to make it more representative of the community as a whole. You can do that type of calculation on the back end, and we do it all the time. And so I think that we do need to just start gathering the data. We need to start gathering the data that is currently not being captured, because if we don't, we are going to miss it. Mm-hmm. The other thing we're also not doing right now, which I'm really worried about, is I feel like we are missing, because people are now testing at home. It used to be that one of the main markers of flu is coming is something called syndromic surveillance. Right. People coming into the emergency department and they have fever and cough. And we, even though they don't test positive, because a lot of times people won't, because they're you know, several days in, we'll know based on the numbers of people coming in with symptoms with this syndrome that's associated with the flu, and we'll make decisions based on that. CDC relies on that. But now that everyone has a home antigen test, they're not coming in anymore. They just test at home. And so even that symptom data is not being captured. So I think we need to do both. We need to get better access to symptom data, and we need to get better access to home antigen test data. So if there are people on this call who are good at, you know, programming, I would love to talk to you about things that we can do together to try to beta test this, because I do think Seattle is really a hotbed of innovation in the space, and it would be really great to sort of think together about ways to capture this data and maybe provide a way for the nation to follow. So.
Definitely. And Dr. McNairy also mentioned endemicity, and I think we might be having some technical difficulties with her.
I can hear you.
Oh, okay.
I'm just having, it's like how it happens in global health. I'm going to try to get you my picture up as soon as possible, but I'm here.
No okay, great. So yeah, you mentioned endemicity. And so, you know, just for those who aren't quite familiar, what does that mean? And are we there yet in your opinions?
Okay, I'm going to start the conversation, then it's going to go back to Dr. Chu as the expert. I think of endemic as you're transitioning to sort of a constant rate of a pathogen in the community, and it's going to be with you for the long term. Now, typically, we like to have our optimism hats on and be like, it's going to be at low levels, right? And it's going to have low severity, and that makes us all feel comfortable. We are, yes, transitioning. COVID's going to be with us for a long time. So, like, first part of the definition is a checkbox for me. But the second part of the definition is it at low rates? And the answer is no. And is it decreased severity? With vaccination, it is, but we're still having so many deaths. I mean, let me just reiterate for the people on this call, like, we are not where we are with flu. There's under 100,000 adult deaths of flu in the US for my check, and Dr. Chu's going to double check me. But, you know, COVID, there's 1 million deaths. I mean, we're not at lower the flag yet. But Dr. Chu, go, and I'm going to try to get my picture up, and I apologize to everyone.
Yeah, I mean, I think that it's important to think about it, but it's not the main, I think it's not the main message right now, right? So we're still in a period of time where this is causing severe disease and deaths, and we're still not stable. And so eventually, this coronavirus will become like the other seasonal coronaviruses, which hundreds of years ago did the same path of going from a bat to something else like a pangolin or a camel or something, and then over to a human. And then over time, it just became endemic. But that takes years and years and years. If we look back at the lesson of 1918, people were dying at high rates for several years after that first year. And a lot of it was because people were tired. I think people were tired of the restrictions and did not want to do them anymore. And I think that we're in that stage, that people are tired. And I understand why people are tired, but we're not at a point where we have mild disease due to a seasonal coronavirus or a seasonal flu, which is not actually that mild. But I mean, there are some things that have been good, right? Masking has decreased the amount of the other viruses significantly. A lot of the masking, the distancing, the hand hygiene, the staying home when sick, all of these changes in our behavior that are probably fairly long-term changes will probably reduce the risk of these other respiratory viruses over time as well. I don't think we're ever going to stop masking in hospitals anymore. I don't think that's going to happen because we now know that that actually prevents flu transmission and flu deaths, particularly in the very vulnerable. So.
Definitely. And what, you mentioned people are really tired. We've been hearing that as well. And so, what can you say to people right now before we turn over to some audience questions? What can you say to those who are just feeling really demoralized right now about where we are in the pandemic? Disease levels are still pretty high, especially in Seattle, King County area. And we do have high vaccination rates and other mitigation efforts. But, is there anything else that each of us could do and should be doing to protect ourselves and families from this next pandemic potentially?
I could start with saying, like, our toolbox is so much better, right? Like, remember the story I gave at the beginning of the talk, March, like we were overwhelmed, patients were dying, and we were radically helpless. Now we're not. We have prevention, vaccines, plus mask and social distancing. And we can flex on those mask and social distancing as needed, right? Like when we're not in areas of high alert, like come down, you do more socially for sure for mental health. And then the toolbox for treatment, I just think is night and day different, both for outpatient people, individuals, and for hospitalized patients. Transforming, like we do in other epidemics, a disease that almost had a fatality rate that was, once you landed in the hospital, be extremely high to we can get patients through.
Yeah. I mean, I think that we know what works. The other things that I would say that we've really accomplished in the last 2 to 3 years is some real forward progress on how quickly we can make vaccines and how quickly we can make vaccines that are specific to the pathogen. So the genetic vaccine technology is incredible, and it's also importantly fast. And then I think the other things that we've also been able to do is expand testing to the home, which with it, even though it has lots of limitations, is sort of a game changer in how we handle diagnosis of infections, because we know that if you know what you have, you change your behavior, right? So that's really important, and that's also technology that can now be applied to other pathogens as we move forward. And then monoclonal antibodies, I think that's also been an amazing thing that's happened in the last 2 to 3 years. The ability to draw a blood sample from an individual and then to turn it into a therapeutic, also within the space of months. I think these are lessons that we've learned in this pandemic that make us much, much better prepared for next time. So we can use those tools that we have. And I think this is not over, but I think we are better prepared for what is to come. And things are only going to get better. They're not going to get worse at this point. So.
And I would add, Elise,
fingers crossed.
As doctors and researchers, we can do certain skills great, but we're not so good at public health messaging, to the level of journalists and media experts. And I think the messaging to the communities to understand that this is with us for a while and to alleviate that cumulative like fatigue. It really, we have to all share that burden. And I think there's a real role for the media and Murdoch Trust and talks like this to give people hope, but also set expectations, because you're only disappointed if you have an expectation of something else. But if you expect of what the road looks like ahead, you're less disappointed and you feel more robust to be able to endure it. So anyway, thank you for your work in COVID. And I think we need more and more people going into journalism to do public health messaging.
Thanks, Dr. McNairy. It's definitely dwarfed by the work that you and your colleagues are doing. But, speaking of which, and you brought this up, but, this is a question from the audience, and how concerned should we be about the road ahead in terms of other pandemics and future global health crises? For example, we've recently heard about monkeypox landing in the US for the first time, and since then there have been other cases popping up. But, should we be afraid that every next virus is going to be the next COVID?
I think that we should be prepared for another pandemic respiratory virus to come along. There's just, the recipe is there, right? The human animal interface, the fact that people are traveling from place to place very, very quickly. And just based on what's happened in recent history, we've seen that the pace of these novel viruses being discovered and leading to outbreaks, that pace has accelerated significantly, even within the past 20, 30, 40 years. So it is coming, but we are better prepared than we were in the past, substantially better prepared. I mean, I can list out all the ways that we are not prepared, but to be optimistic about the fact that we have these technologies, vaccines, monoclonals, testing. We know masking works. We know what kinds of things you need to do at the beginning to be able to, slow down the spread and to flatten the curve a bit. I mean, I think that we are in better place, but yes, we will have another pandemic.
I just make the plug that we are proportionally, we're in a lot better place in the US and developed countries, but globally, systems are still weak. And respiratory viruses don't have boundaries, nationalistic boundaries. And we have got to create the delivery systems to get faster. I call it, with a friend, port to arm, vaccines in the port to people in their arm. And I think the horse is out of the barn for COVID. Many people already have natural, infection and immunity from at least some partial. And in Africa and Haiti, 90% in a study we just did in Haiti have antibodies, yet less than 1% are vaccinated. But there's another respiratory virus coming, and we lose interest as Americans often, in my opinion, once we're feeling better, and a lot of the world's still not feeling better. And I think this just underscores, like, respiratory more than anything else. Respiratory viruses are global faster.
And a quick follow-up to that too. We saw that COVID especially hit so many communities of color disproportionately. And so for next pandemics, are there any, what should the main lessons be boiled down to in terms of how to address that and how to prevent that?
I again don't have all the answers. I want to be part of the solution. And I think it's multi-pronged, spanning, a lot of Americans, particularly people of color, don't have access to healthcare. I can't tell you how many hundreds of patients and friends and family called me because they don't have a primary care doctor. Mm-hmm. Building a robust healthcare access system in America with, affordable primary care is key for surveillance and for rapid diagnostics and for, this is COVID, a primary care disease. It should be a primary care disease. I think building, like Dr. Chu said, more community partnerships around messaging and trust and who the messenger is. I've never found a patient, no matter what their background, religious creed, political affiliation, race, who, once you develop trust, didn't want to take steps to improve their health. And I think this points to a larger, crisis in America of social and racial health disparities that are not necessarily getting better. And COVID has put a, zoomed lens on that.
Definitely. Thank you so much. And pivoting a little bit, we have a lot of audience questions. So going back to the strain on healthcare workers and anyone who's working in public health. So can you both describe how you provided emotional support to clinical staff and how that continues?
Sure, I can start. I'll add another statistic for that person who asked the question. It's not just healthcare providers, it was public health experts. There's an interesting statistic that 40% of county health commissioners resigned or transitioned in their duties because of what? Stress, politicalization of COVID, lack of resources, all sort of suggesting this burnout and this crisis. I found in my practice with peers, doctors, and residents and students and nurses, affirmation of acknowledging the shared experience goes a long ways. And I think a lot of times there's not even been space to affirm and name the problem of the stress. So we're doing a lot of work around space to do that. That's on the clock. And then trying to offer a lot of mental health services, both expanding health benefits and offering peer groups here at the hospital. But I'm interested in even the audience may have a lot more suggestions for us because a lot of it is reverse innovation, and just because we're physicians and supposedly mental health experts, we are not doing it well.
Yeah, definitely. Is there anything, Dr. Chu, you'd like to add to that about what you've seen in this area?
Not so much. I have not spent a ton of time in the hospitals, or I mean, certainly as a practicing clinician, it has been hard, but I think it's just, I probably have the same burnout that the general community has. And there has been very little to be done to address that, particularly in academics. So.
Mm-hmm, mm-hmm.
That's true. That's true. Yeah. The academic model is it's not modern.
Mm-hmm. Got it. Okay. And so another question organizationally, how can organizations and businesses and nonprofits and the community plan, but not overreact or underreact when it appears there's a new wave of COVID or another virus coming along? Is there anything that you can advise to people to just kind of stay as measured as possible, depending on the circumstance?
I can start. So if you think of it as like there's a clinical, like there's individual level, you need to have a preparedness plan for your own risk. It's based on your risk profile. Do I have heart disease? Do I have an immune compromised system? Then there's the population level, like Dr. Chu's building rapidly and extraordinarily. And then as businesses, you're somewhere in the middle level of, I try to help schools and organizations and businesses have a base preparedness plan for risk reduction. And it's not complicated, and it's definitely not rocket science, but it has to do with communication plans, social distancing, masking, and management of cases when they come in. And employees want that, and and I think whatever companies can do to build that now can be used again and again and again and strengthened over time. Without it, you're going to go back to shut everything down, which no one wants to do. So I think there's a real role for capacity building, for teaching workplace safety, and maybe that goes into workplace wellness for businesses and organizations. And I think there's going to be a growth in that industry over the next 2 to 5 years. Should be yesterday, but takes a while.
Yeah, absolutely. And what do you think is the best way for people to stay informed about new things that come along? I know one of the big issues throughout this entire pandemic has just been how much things have been changing and different guidances have changed. So what would you recommend to just stay most up to date without feeling too overwhelmed by COVID news?
You should start the answer with that.
I sure don't know.
I think that generally the public health messaging is pretty good, at least in Seattle and King County and in Washington State. And a lot of these systems have already been put in place in terms of sort of levels of risk and levels of community transmission. I think what has happened in the last several months is, or not just several months, but several years now, is that people have lost trust in that messaging being completely transparent and also being not biased by politics. But those things are in place. You know, we have stratifications for level 1, level 2, level 3, and what you should do in each case. But I think people, the community, don't trust the messaging. They don't trust that the data that's coming in to feed those models is the right data. And I agree. I mean, I think that there is very little data, and the way that the CDC has presented some things has been very unclear, and especially around masking guidance. But and if you look at other countries, everybody has a pandemic preparedness plan. If you look at the UK and in Israel, what they have that's different is national data systems that capture the information accurately to feed those guidelines. And that is what we are missing. We don't have that data that's giving us the accurate information to be able to say, hey, community transmission is very high right now. This virus, this particular variant is arriving in X number of days. We know that it's going to lead to this much transmission. Therefore, start masking now. And so my hope is that with the changes that are coming nationally and in our state, that we will get to that space where we have the accurate data feeding in, and then the sort of the tiering will happen, and that guideline will come from public health, which is, I think, the appropriate place for it to come from. So,
you know, in public health school, they teach you, I don't know if I have it quite right, but like there's 3 tenets of public health messaging. It has to be data driven, and it has to be timely, and it has to be transparent. And with those 3 things, sometimes you have an answer for the public, and sometimes you have an I don't know. And I don't, you know, I think with politics and the need to be, you know, some people feel like they're an expert, they have to have an answer. And versus, you know, staying true to those 3 tenets, which is sometimes here's the data, I'm giving it to you, I'm being transparent, and here's what I think it says, and here's the questions that it doesn't answer yet, and therefore I'm going to go get more data.
Yeah, absolutely. Well, thank you both so much. We only have a few more minutes. Unfortunately, I feel like I could, you know, have this conversation for hours, but before we turn it back over to Colby, do either of you have any closing comments?
I was just going to try to answer some of the vaccine questions that have come in, because it seems like that's quite a bit of it. But I would just say that in general, that the vaccines that are currently in development, particularly for the under 5 group, they have been extensively vetted in thousands of children, and that we do have the experience from the 5 to 12 and the teenagers as well to show that these vaccines are safe and effective. And so even though you can look at the information and say, well, it took so long to get to this point, it was because along the way, they found things that required them to keep on doing more studies. So for example, for the Pfizer vaccine, the reason why there is a 3rd dose is because they found that the 2 doses alone were not generating the high enough protection that they wanted in young children. So for me, when I see that delay, what it reflects to me is that they were careful and that they made the right decisions and spent the time to generate the extra data to make sure that it was correct. Obviously, this still needs to go through FDA and then CDC, but the data, I think, will be presented to the FDA and the decision will be made. And I think what the FDA decides and subsequently what the CDC recommends, I think that is to be trusted. So.
And Dr. McNairy, did you have any final thoughts you'd like to share?
Thank you for having me. I wish I could see all your audience faces for connection. And just remember that we are a global community. And I feel like this is an obvious statement, but so many times I feel like we nationalize like our thinking around COVID, be it vaccine procurement and distribution or what needed to be done. And really respiratory viruses, among any other pathogens, have no borders. And until we build up, you know, our strength will be dependent upon the weakest link. And just this obligation as humans in society to take care of those who are living in lower income countries. So thank you.
Absolutely. Yeah, I'll hand it back over to Colby, but thank you both so much for all this excellent info. It's so helpful to hear from both local perspective and global perspective. So I really appreciate having this talk.
And thank you, Elise, for doing such an amazing job of guiding today's conversation. And on behalf of the entire audience, I also want to express sincere gratitude, Dr. Chu, Dr. McNairy, for your expert wisdom and thoughts today. Also, we want to thank all of you who joined us for today's conversation. We will be emailing a link to you with a recording to today's conversation, as well as some registration info for our upcoming conversations if you're able to join us. Until then, we hope everyone has a wonderful rest of your day.